Welcome everyone to the last session of day 2 of the ACU virtual conference. My name is Sabrina Edgington. I'm the event planner and also the Director of Learning and Curriculum Design at ACU. This last session of the day is Collaborative Care, a clinical and financial opportunity for health centers. It is eligible for 1 CME credit through the American Academy of Family Physicians. So in order to get credit, you'll just need to make sure you attend all the conference sessions that are eligible for the CMEs, and then complete the session evaluation for those that you want to receive CMEs for. So if you have any questions about that, let me know. If you forget to complete a session at the end of a conference session, if you forget to complete an evaluation at the end of a session, you can always go back to that session in Crowd Compass. So if you go to the session in Crowd Compass, scroll down, you can get the session evaluation and complete it there. And then in 2 to 4 weeks, we'll send you your certificates. So some housekeeping, please use the Q&A box to ask questions, ask them as you think of them. Dr. Little is really great at responding to questions as they come in. Also, if you're having any technical problems, please use the chat box to message Rick Brown, the host, and he can help you through that. We are recording, and we'll make the recordings available through Crowd Compass, so you'll be able to access recordings in the exact same way that you access sessions in Crowd Compass. And then again, please complete that evaluation. So with that said, I'd like to introduce Dr. Verna Little. Dr. Little is the founder and COO of Concert Health, which is an organization that provides behavioral health services for primary care providers. She's also the founder of Zero Overdose and has worked in with health centers for over 20 years. So she brings a wealth of experience and knowledge to us, and we're so grateful to have her. And I'm going to hand it on over to you, Dr. Little. And you're on mute.
Oh, okay. Sorry, I didn't know that got muted. So good afternoon, everyone. Thank you so much for taking time out of your day to talk about collaborative care. I'm really excited to talk to you about what health centers are doing around the country around collaborative care. And again, feel free to ask in the question, or I will be watching the chat throughout the presentation. So feel free to type a question or a comment in to everyone, or feel free to send something to me privately, and we'll make sure that we either talk about it during the presentation, we can stop and have some discussion, or certainly leave some time at the end for collaborative discussion. So when we think about integrating behavioral health into primary care, one of the main things these days is really access and serving patients where they are. And as we know, many patients are in community health centers. And it's super important now, and I'm going to talk about this quite a bit, is to start to think about clinical outcomes for your behavioral health population, as well as making sure that you have sustainable and viable services. So we're going to talk a lot about that as we go, and glad to answer any questions. So when we think about depression care, really most community health centers now are caring for patients with depression. And when we think about the number of prescriptions that are written for depression or anxiety, most of them are actually written in primary care and not from psychiatry. And one of the things I know when I hear, primary care providers talk about behavioral health is that they feel like it's kind of this black hole. There's never enough services. They aren't able to get people in. They never really get the information back. And so this really is a model to help you think about how you care for your population of patients who have depression. And again, you're going to hear me say, oops, I always do this with WebEx. I'm sorry. Oops, it's not going. Let's try this again. Okay. So we're going to talk very specifically about collaborative care. And I really want to just take a moment to think about integrated care and how you talk about integrated care and different models of integrated care. And we're going to, I think a lot of times people really think of them as interchangeable, and they are not. So oftentimes I ask people about collaborative care and they say, oh yeah, we do collaborative care. We collaborate around care all of the time. And so collaborative care is a very specific evidence-based model. It was developed by a psychiatrist that is out on the West Coast, and he used to go into a primary care practice one day a week or one evening a week, and when he went in, he would just get slammed with patients, and he would sit there and think, am I seeing the sickest patients? Who decides what patients do I see? I never get to really communicate with the primary care providers. I don't really know if people are getting better. And so he really developed a very systemic model, which for the first time actually worked to identify and treat patients with a behavioral health diagnosis in primary care. And essentially, it is now an evidence-based model, and it has been shown to be effective in over 80 randomized control trials. And the collaborative care model introduces two people to the primary care team, a behavioral health care manager, and we'll talk a lot about who that could be, and a psychiatric consultant. This psychiatric consultant does not see patients. They actually provide recommendations to the primary care provider. And one of the things to think about with the collaborative care model is that it is really important to start to think about your entire population of patients with depression. What often happens now is somebody will come in, maybe you screen them for depression or they're crying in the primary care office, and they get referred to behavioral health. Maybe they go. Actually, most patients don't wind up in behavioral health care, and if they do, the average number of sessions is about a month's worth or about 4 sessions. So not only do most people not get there for lots of reasons, which we could certainly spend time talking about, but they don't tend to stick. And so what happens is that a lot of people wind up not in care that were referred. The other piece is that we really don't have a lot to offer patients right now. So if I make a behavioral health referral from primary care, I really get therapy. I get some traditional therapy. And that, if I don't take that or I don't want that, then there's no other options for me. And what we also find is that very few primary care providers really optimize their behavioral health services and often have access to limited services. And so what happens is, as an example, we had a practice recently that I was working with, and they had 8 providers in Arizona. And they had about 30 to 40 patients that were enrolled in behavioral health services. And then we really talked to them about identifying and caring for their whole population of patients with depression, because really they didn't have any idea how well those patients were doing, how many there were. And so they ran a report, and there were over 1,700 patients that were on medications for depression and anxiety that really were on nobody's radar in terms of really being followed to ensure that they were getting better. And so the collaborative care model is really meant to help you manage your entire population of patients with depression and anxiety in an evidence-based way, and introducing these two new team members. So the behavioral health care manager generally is a social worker, but it could be other disciplines. It could be a counselor. It could be a psychologist. In some cases, it can be a nurse, and I'll talk a little bit more about that. This behavioral health care manager is introduced to the team. They provide care to the entire population of patients with depression or anxiety. They make sure nobody falls through the cracks. They have a registry. And the most important thing to understand about collaborative care is it actually gives people choices for what's going to be helpful for them in terms of how to help them get better and reduce symptoms with depression and anxiety. The consulting psychiatrist can be a remote person. They don't see patients. They provide consultation weekly to the behavioral health care manager for patients who aren't getting better, and they give those recommendations to the primary care provider. So what that means is that they can actually touch way more patients than they could if they were actually in the practice for that hour. This original collaborative care was called Impact, and many of you might have heard about it. It was a large study in the late 90s, early 2000s, 1,800 adults, over 400 primary care providers, and rural, urban, and what they found when they put a system in place to really identify patients and to care for patients with depression and anxiety, they found that they got better. And so I like to tell the story about number 7 here on the chart, because what happened is when they were recruiting practices to enroll in collaborative care, they asked one practice, and the practice said, well, we have an embedded behavioral health provider. We kind of already do this. And so they were not going to put them in the study. And then the medical director said, you know what, I actually think we could do a better job. And so what this shows is that when you put a system in place to really care for patients, then you get improved results. And so it's kind of like your diabetic population. You have a population of patients with diabetes. You know how many patients with diabetes you have. You know how many are controlled or uncontrolled. And you know what your average A1Cs are. You know what patients need to do to be able to get better. And so you have a sense of that population. However, with our depression patients, we don't often have that. And so one of the things that we saw when we really put a system in place is that patients got much better. And we'll talk about what that means and how we measure it. That they had less physical pain. And in fact, what we saw is that initially the costs went up because people said, oh, you know what, I'm feeling less sad or less anxious, I will get my knee done. I'll start going to the, specialist. And so you really saw people just re-engage in care in ways that they hadn't done before. And so that's been incredibly helpful for health centers. And I will say that one of the things that, many years ago, I was fortunate enough in an F2HC network in New York to be able to duplicate that research trial for the first time in the real world. And I chose patients that our chief medical officer and our CEO were seeing. And after a month or so, they came and they're like, what are you doing with those patients? Like, how can we do this more? And that's how we actually started to do collaborative care. So the thing about collaborative care is there's some very core principles. Collaborative care, the model, is now recognized by Medicare. It is a Medicare benefit for Medicare beneficiaries. It is also on the Medicaid fee schedule in 19 states, the latest I think of which was Michigan. And in some states like Illinois, they actually put it into law so that even the commercial plans had to recognize it. However, our experience nationally is that the commercial plans are recognizing and paying for collaborative care as well. And so essentially providing this model of care is covered across your entire payer mix, and we'll talk about what that looks like. So the core components of collaborative care, this is incredibly patient-centered. So if you remember, I talked about how patients sort of got therapy or that was their only choice. Collaborative care is very patient-centered. It can happen telephonically. It was happening telephonically before it was even fashionable with COVID, right? So patients have a choice. It can be in person, it can be by phone, and that can alternate. It can change every week if they want it to. The other piece is that there are options other than therapy, and therapy is one option. But also, I will say to people, it's really important that we know how well you're doing. Some people find it helpful to have check-ins, maybe every week or every other week, symptom monitoring, if someone starts a new medication adherence. A lot of patients like goal setting. So, sometimes when you make a New Year's resolution and you tell somebody about it, they say, you're more likely to keep it. So goal setting is one that I actually use most often with patients, and maybe talk to them every day or every couple of days when they first enter into collaborative care. What's something you might do today or tomorrow that might help you feel less sad? And then I really partialize that down. So I had a gentleman the other day, and he was going to he was going to exercise, and or the doctor had told him to go outside. And so he was like, I talked about it to the doctor, but I'm not really gonna do that. I haven't been outside in months. I just pretty much sit in my apartment, in the dark. And I said, well, okay, what's something you could do, like today? What's something you could do today? And he said, well, I'm not really sure. I've just been sad for a long time. And I said, well, what would it be like if you weren't sad? Like, what would your day be like? How would it be different? And one of the things he said is that there would be light. And what he meant is that he hadn't opened his window blinds or his curtains in a really long time. And so one of the things we did while I was on the phone with him was he went around his apartment and he opened the blinds and he opened the curtains. And we talked about what we saw, and we talked about how it felt, and we talked about how the sunshine looked in his apartment. And so those are the kinds of activities that we do in collaborative care. And people have choices. People can pick all of the choices. Yep, call me, talk to me, make sure I'm, really taking my meds, not having any side effects. Yep, let's set some goals. Let's see how that works. Yeah, it'd be really nice if somebody checked in on me and see how I was doing. Oh, yeah, it would be helpful to talk to someone at the same time every week. That would probably be helpful. And so patients can choose all of those or one of those, or they can switch it. And it can be in person or by the phone. So it's really about what works for them. And so what you find is that you actually engage way more people into care who are getting behavioral health interventions, and that they stay in care longer. So the average amount of time in collaborative care is about 6 to 8 months. And this, again, is about your population of patients. So it's every patient that you have on medications, every patient that scores positive on a screening tool, every patient that's identified with depression or anxiety on a problem list, and having a registry so that no one falls through the cracks. And I can share with people who are interested, there is an Excel registry that you can use that's often really helpful for people, but it is your population. And one of the things we know about implementing collaborative care, if it does not work, if you just have a behavioral health provider and you put them in a primary care practice and you have it based off of provider referrals, you really need to take a population health approach for your entire population of patients with depression and anxiety. So treat to target. I would love to know how many of you on the webinar know what outcomes are for depression and anxiety. If you have outcomes that you follow in your health centers, or if you know what the outcomes are, because collaborative care is very treat to target, right? It is designed to really monitor and reduce symptoms of depression or anxiety in 90 days. And so it is a 50% or 10-point reduction in the PHQ-9, which most of you are familiar with for depression and do as a regular routine part of having patients come into your centers, and the GAD-7, which is for anxiety. So looking for a 50% or 10-point reduction in symptoms. What's interesting to know, and again, another plug for doing collaborative care, is that UDS and HRSA is going to start to ask health centers for outcomes for depression care. And so this is really going to help you get some systems in place to be able to do that. So collaborative care itself is evidence-based. It is an evidence-based practice, and I like to think of it as an umbrella. And under the umbrella, there's other evidence-based practices that the behavioral health care managers use, such as behavioral activation, setting goals, motivational interviewing to see where people are, problem-solving treatment, which helps people take a problem and partialize it down, cognitive behavioral therapy, interpersonal therapy. So all of those are evidence-based for depression or anxiety and are used in the care and treatment of patients in collaborative care. The other piece that it's accountable. And you are accountable for your population of patients, and you're really looking to make sure that at least half of your patients are having a decrease in your depression or anxiety scores. So 50% of them are reaching that benchmark of a 50% or 10-point reduction in symptoms. So this is a pretty picture of what it actually looks like in practice. So you have your behavioral health care manager that does lots of work with the patient, that communicates with the primary care provider. They have a registry, so all of the patients go on the registry. And right now there's only one EMR that really meets the criteria for a registry, which is Epic. So others, we can certainly give you some suggestions about what to do. And then you have the psychiatric consultant. So again, that psychiatric consultant meets with that behavioral health care manager weekly. They go over patients that are not getting better, and then they provide recommendations to the primary care provider. So the thing to know about collaborative care is that is not a behavioral health program or service. It is primary care. The codes that are used to bill it are primary care codes. So a lot of organizations make, particularly health centers, make the mistake of implementing collaborative care and putting it under behavioral health. And oftentimes that's really problematic because it's a primary care service. And so not that there aren't connections to behavioral health, but it really changes how something gets implemented and understood if it falls under primary care. Oh, sorry, I am having troubles here. Let me just make that smaller. Okay. So what does the primary care provider do? So again, these are primary care codes. The primary care provider is the billing provider. These codes are not billed under the behavioral health provider, even though the behavioral health provider is providing a majority of the services. So the primary care provider, there has to be a referral in the chart for the services. They oversee the patient's care. They prescribe the medications. They're the ones that would introduce collaborative care many times. So I work with Verna. She's part of my team. She helps me care for my patients who are feeling anxious. I'd like to have her give you a call later today. And then really works with the psychiatric consultant to make sure that patients' recommendations are followed, or if they have any questions, that they can ask questions about medications. Maybe if a patient had a new diagnosis and they're wondering about medications, then certainly they would ask the psychiatric consultant. So the behavioral health care manager works really closely with the patients and the primary care provider. They provide a lot of the engagement activities and education. They do all of the follow-ups. They're the ones that make sure, so they're checking those PHQ and GAD scores to see who's getting better. They're providing medication adherence and information. They're doing some evidence-based interventions, and then they're also preparing relapse prevention plans. No one should come off of collaborative care without a relapse prevention plan, so that people are able to identify, when they're starting to feel sad or anxious again, have some coping skills to be able to put in place, and if not, come back to their primary care provider. So the psychiatric consultant often is a contracted person who calls and talks to the behavioral health care manager weekly. It is super important that they have access to your electronic health record. It does not work if they don't have access to the electronic health record. One, because they need to put their recommendations in there, provider to provider. And second, because you want those consultation notes to be able to be in the chart. And third, it's really problematic for something to be cut and pasted and put by a non-prescriber in the chart. So they really spend time, and they don't only consult with patients who are on medications. They will also talk to the behavioral health care manager just about treatment modalities, or maybe some symptoms that somebody's having, and think about different diagnoses. So it's not just patients who are not getting better. And also to note about psychiatric consultation for Medicare patients, Medicare actually requires psychiatric consultation for patients every month. That is actually not consistent with other payers and not consistent with Medicaid. what most state Medicaid has put in place. It's actually something they're going to change because it's not necessarily consistent with the model, but it is a requirement for Medicare patients to happen at least once a month. So the patient is really given a lot of information, particularly about, their scores. So a lot of times where we lose patients to depression care in particular is that we often do the PHQ-9. We talk to them about their depression, but we don't actually talk to them about the scores. So I know that when I go into my primary care practice, to my provider, right, they take my height and they take my weight and my blood pressure. They do it every single time. And they have no qualms telling me, well, this is what you weigh and this is what you should weigh, much to my dismay, right? But they're very clear about telling me. But often we don't tell patients what their score is on the PHQ. Listen, you're a 21. We'd really like you to be a 5 because that's really where I like to see my patients, so that patients know where they are and where they need to go. So that is a really huge deal in terms of really explaining that to people, because then what happens is we talk to to patients, and then maybe they start a medication, they come back, how are you doing? Oh, I'm doing better. And so they don't actually know that better is not as good as it can be, or if they scored a 14, they don't really know that they're, looking to be down around a 5. So it's really important to talk to patients and to let them know and to say, hey, listen, like we measure your blood pressure, your sugar, we have a way to measure now, how you're feeling. And you've talked to me about feeling sad today. And, we have a way to measure it. It's going to be really important that I know how well you're doing as we go on this journey. And so I usually tell patients at least twice a month to know how well they're doing and to be able to do the tools with them. So, because remember, you've got 90 days for that 50% or 10-point reduction. So it's really important to make sure that you're being very proactive. So I was in a practice the other day, and they said their standard was if they started somebody on treatment that they would bring them back in 6 weeks. And I said, in 6 weeks, you're halfway through your goal time. So you need to be able to think about what that, how that looks and looking a little different. So a lot of times primary care providers will say to me, well, does this mean I'm going to see patients more? And the answer to that is not unless you want to, right? So I've had some providers now say, listen, bring patients back in. We're still trying to ramp up to get back where we were pre-COVID. So we've been working with them to do that. But most of the time we see that the primary care providers still see their patients about 3.5 times a year, but that they have lots of contact with the care manager. They have some consultations with the psychiatric consultant. And so they're getting a lot more touches. I like to think about it as a warm, fuzzy blanket around your patients with depression or anxiety. The other really important piece to note is that most patients, I actually will say pretty much all patients will need a change in treatment. So I say that right from the beginning. It is very seldom that what we start out doing with someone with depression or anxiety actually works so that you can meet that 50% or 10-point reduction. Often patients will need a new med or to start meds, to augment a med, to add talk treatment or to add some check-ins or goal setting, that there's something different that needs to happen. And we often will find that we need to change at least 2 or 3 times to keep someone getting better. So I prepare that with patients right from the beginning and say, we've learned a lot about helping people who are feeling sad get better. And one of the things we know is that we're going to have to keep throwing some things at it, to make sure that you're getting better. So we're going to try something different. I just want to let you know that we're going to be really proactive and we're going to keep trying things until you're feeling better and we're on the right path. And so it's super important to understand that and also to have that conversation with patients so that they don't get discouraged. Also to think about your registry. So there's always a single source of truth, which is your electronic health record. So all of the documentation goes in your electronic health record, but it is a requirement for collaborative care to have a registry for your population of patients. So the registries are nice because they help determine maybe who's not getting better and needs to be brought to psychiatric consultation. It can also help with billing, which I'm going to talk a little bit about later. So the registries are important, and it is required. So if you look at the guidelines for billing collaborative care, they talk very specifically about a registry. And in a lot of states, they will actually talk about a registry as well in some of the billing guidance. So it's super important to have a registry set up. And again, I can certainly, ACU has my contact information, or I'm glad to put it in the chat. People can reach out to me, and I'd be glad to send them a copy of an Excel spreadsheet that they can do or use while they're getting started. So the way that collaborative care works is that there's a treatment or a care plan developed with the patient that's shared across the care team. And one of the things that is really nice about collaborative care as well is for organizations that are trying to get their PCMH or NCQA or some of those other, integrated care credit or, in that process, then these care plans can be shared care plans and can be put in the portion of the chart so that the organization gets credit for these care plans. And care plans are a living document. They get changed all the time. So for that gentleman that I work with him to open his window, we changed his care plan every day for a week because every day he was doing something different. And so we needed to revise it and set new goals, and we need to switch it up a little bit. And it is incredibly flexible. It's always being modified and changed as goals are being achieved, and using that PHQ or GAD to continue to measure those outcomes. Whoops, I think we're missing some slides. So I'm just going to back up and talk a little bit about what the billing looks like. So these are primary care codes. They are billing by the month. So they are monthly case rates. So for some of you who are familiar with chronic care management as an example, then chronic care management is billed in that monthly case rate. So collaborative care is also billed in a monthly case rate. And this is why it's an enormous opportunity for federally qualified health centers, particularly in the states where Medicaid has put collaborative care on the fee schedule, because then you can bill across your entire payer mix. So the way that it works is the behavioral health care manager will track the minutes that are spent on billable activities for the month. So those billable activities are any telephonic or in-person care with the patient, any time spent with the psychiatric consultant, any time talking to the primary care provider, any time updating the registry, so not entering information into the EMR, but time spent updating the registry. So a lot of times when I'm talking to a patient, I'm documenting in the electronic health record. And then what I do is I will actually then afterwards go and update my registry. And so the way that it happens is generally we recommend that care managers keep one running note in the electronic health record for the month. And we have workflows that I would be glad to share with any of you for ECW, for Athena, for Epic, for MedEnt, some of the more common electronic health records. We have workflows and suggestions for really doing collaborative care. But generally, the care manager keeps one long running note, and they will continually enter in information and the amount of time spent. So one of the reasons we do this is because collaborative care often has lots of touches. And so what happens is that they clutter up the charts, and then it's hard to go and add up all the minutes at the end of the month. So what we do is recommend that the care manager have one long running note, add up the minutes at the end of the month, change the authorizing provider to the primary care provider, and add the CPT codes. So that's a little bit of a different workflow in different EMRs. Some places you have to create a separate super bill, but that's generally how it works. So again, this means that the behavioral health provider can be multiple disciplines. So as an example, for many parts of the country, behavioral health providers are hard to find, and oftentimes there's a lot more counselors, licensed professional counselors or LMHCs, LMFTs. Those professions or those licensures are not recognized by Medicare, so they cannot bill Medicare directly. However, in collaborative care, the way that the CMS guidance is written is that because these are primary care codes, those providers can provide these services. So somebody who's master's prepared, so I can't tell you how many health centers I've had that have hired a master's level student, brought in a master's level student who has done this work and actually kind of worked themselves into a job by the end of the year. And so the way that the wording is that the person doesn't have to be licensed. However, they have to be able to provide the spectrum of care under collaborative care, which includes therapy. And so a lot of organizations will say to me, well, we have these community health workers and they could do some of this, or we have some of these other folks, we have some nurses. And so the reality is they have to be able to provide the spectrum of services. So the original impact study did actually use nurses. However, things have changed a little bit, and I know nurses who are great care managers and they do an amazing job. For health centers, it doesn't always make sense financially because you actually pay an RN more than you pay a behavioral health provider, and you need them for lots of other things. So it doesn't always make sort of financial or operational sense. But technically, as long as they're trained in all of the interventions, then they're able to do it. And so this means that you have a lot more opportunity. And because these are telephonic, then someone doesn't have to be on site. So for example, I had a health center network that was rolling out collaborative care. And what they did was they actually hired someone. They had 4 sites, and then that person covered collaborative care in all of the sites. And then as they got full, they hired a second person and put that person in the second site. So it also helps in terms of who you can hire, because they just have to be in the state or licensed in the state or be a provider that can provide the scope of services. And it really broadens who you can hire to be able to do some of this work. And so really thinking about what that looks like. So the caseloads for collaborative care look way different than traditional behavioral health services and primary care settings. The average caseload is 90. And that's because these are not patients who are getting weekly talk treatment. These are patients who are getting information on medication, are doing goal setting, are checking in, are getting relapse prevention. Generally, about 20% of people will actually choose talk treatment. So one of the things that I will often do is ask care managers who are doing collaborative care how many patients they have, and then how many patients they have that are in talk treatment. And if they tell me most of them, then I know that they're not really doing collaborative care or really giving patients choices, that they're sort of leaning towards a more traditional behavioral health model. The people that have been in community mental health settings or doing therapy for a long time are often not the right people to do collaborative care services, because they're just very used to one model or to do therapy. And so it often is difficult for them to make the transition. So there are several codes that are really helpful to know for collaborative care. The nice thing is that it is very simple. There are not many codes to use. So for federally qualified health centers, CMS was a little not as generous, and they put some guidelines in place, particularly around collaborative care. The first is that in FQHCs and rural health centers, patients cannot be in collaborative care and chronic care management at the same time. So if your organization is doing chronic care management, then what a lot of health centers will do is take the person out of chronic care management, put them through a course of collaborative care, because that's a much higher reimbursement, and the ability to affect those depression or anxiety scores really impacts the other chronic illnesses, and then move them back into chronic care management. For federally qualified health centers and rural health centers, there are 2 G codes, GO 511 and 512. You'll notice that they're the same for chronic care management. So they are reimbursement for collaborative care for the total amount of minutes for that month. So for health centers who have Medicare and commercial populations, there are actually CPT codes that you use. And there's only a few CPT codes that apply to this. They're 99492, 99493, 99494. So I'm actually going to put those in the chat so that you have them and we can talk a little bit about them. So they are the codes that are used for these services. Oh, yeah. And so 99492 is the initial month of services, and that is 70 minutes. 99493 is a follow-up month of service, and that is 60 minutes. And so for your commercial and Medicare, you would actually use those CPT codes based on the month of service. 99494 is a 30-minute add-on code. And it means that if there's an additional 30 minutes of care, then you can add that 99494 code on to one of the other codes. You cannot bill that code independently. And so what you see is for your Medicare and your commercial plans, there's actually fairly significant monthly reimbursement for providing these services. So generally, a care manager with sort of an average, FQHC community health center payer mix at a full caseload can generate anywhere from $12,000 to $16,000 a month in billable services. And so again, depending on your payer mix, depending on your uninsured rate and some of those other things. But certainly the commercials and the Medicare are significant reimbursements. And Medicaid, depending on your state, most of the states were actually reasonably good in terms of providing, reasonable rates for these services. There are some like New Hampshire and Pennsylvania that are on the low side, but certainly what it matters is really in the volume. So there's a lot of health centers that got HRSA funding. I actually talked to one today. Their HRSA funding was ending for their integrated behavioral health, and they were giving up on their collaborative care program. And I actually wish that I had talked to them when they were first doing it, because they made a lot of mistakes that many health centers make. The first thing they did was that they put the behavioral health provider there. They didn't really train the primary care providers as what collaborative care was, and then how it was different from other evidence-based behavioral health services. The other thing is that they put the behavioral health provider in the practice and depended only on provider referrals. And we actually don't implement collaborative care that way anymore. The way that we really do it is, warm handoffs and referrals from the primary care provider team is great. We love them. They are an awesome way for someone to start collaborative care services. But generally, you really need to put some systemic pieces in place. So in other words, anytime somebody scores 10 or above on the PHQ, as you give it as part of your intake, triage process, that medical assistant, that nursing person refers that patient to collaborative care. That you have decision support so that anyone who is getting a new medication or a refill for a depression and anxiety medication is collaborative care. I'm working with a lot of practices now that are implementing collaborative care, and they're running reports for all of their patients with depression or anxiety on the problem list, and actually working with their collaborative care managers. They have two. to really clean up those lists. So have they been screened? Are they still experiencing depression or anxiety? If not, we're resolving that on the problem list. And if they are, you know, what did they score? There's a plan in place. They're in collaborative care. You know, they're able to really be tracked so that we can look for some outcomes. The primary care provider is aware. And so that's really an important piece, that you have to put those systems in place so that you're really putting those population health measures in place to really build your collaborative care population. So a lot of times people will ask me about copays and how much does this cost for patients. So I mentioned that this is a Medicare benefit and there is a copay. However, the important thing to know is that because these are primary care codes, then the copay amount is consistent with a primary care visit. So generally, when somebody comes to the primary care provider with Medicare, they pay a 20%. So this is 20% of the entire month of services, and maybe that's 5 therapy visits, 2 psychiatric consultations, 10 check-in calls, and it would still be that 1 monthly copay, which generally for Medicare patients is about $36. The same with your commercial plans. So if I were to go to traditional behavioral health services, then I might pay a copay under my behavioral health plan every time I saw the therapist and every time I saw the psychiatrist. So this is for the month of services, and it's consistent with primary care. So if I have a commercial plan and I pay $20 when I go to see my primary care provider, then that's what it's going to cost for an entire month of collaborative care. I mean, assuming patients don't have some higher deductibles than that. But really what it does is it makes behavioral health care way more affordable for a lot of patients. And that's been tremendously helpful. So that, combined with giving them an incredibly patient-centered buffet of things that they can choose from that they think will be helpful, what you really see is people getting better. When you're really honing in and talking to them about symptoms and really saying, hey, you know what, for 90 days, you know, we're really going to work on this, and this is where you are, and this is where we think we're going to be able to get you. And making the distinction sometimes, because patients often have maybe been in therapy before, saying that's an option, but there's all of these other choices as well. And that's what it really looks like. And patients really engage with that and they relate to it. And then I really always try to give patients a very quick treatment success, so that I ask them a very, you know, set a very small manageable goal. And I will often talk to a patient in collaborative care, you know, maybe 5 or 6 times or better in the first 2 weeks, because I'm really building the relationship, setting small short-term goals, having them meet those goals, revising them. And that really engages people into a process. And so it can be tremendously helpful for people. And so when you think about the opportunities for health centers, so you think about the fact that you have large populations of patients with depression and anxiety that you're not really sure how many you have, and you're not really tracking any outcomes now, like you might be tracking your screening. How many PHQ-9s do we give, right? And you might be tracking your rate. So for depression screening in a community health center, we usually say that 10 to 14% of your patients should screen positive with the PHQ-9. And so all of those patients are identified. You really want to make sure that you have a plan or a process in place for them. And that's also going to help you with some of your quality measures around depression care, but it's also going to help you with some of your other quality measures. You know, if I'm really anxious, I'm more likely to go to the ER, right? If I'm feeling sad, I'm less likely to take my diabetes medication or go to the cardiologist. And so these are really 2 diagnoses that can really affect some of your other chronic conditions and some of the outcomes that you're tracking. Additionally, it helps you prepare for what you know is coming, which is some value-based payment, and also having to report depression outcomes into your UDS measures. So it really gets you prepared. And then in addition, it allows you to provide behavioral health touches for way more patients. It allows you to really generate some income and revenue. I have not worked with a community health center yet, and actually my organization provides, services to primary care practices, and I've not worked with one yet that we weren't able to make collaborative care not just sustainable, but actually revenue producing. Most of the time where implementations will go wrong for collaborative care is that there isn't a plan to really keep collaborative care to get it really up and running. And so we do now what we call 30, 60, 90-day launches, which is 30 patients the first month, 60 the second, and 90 the third month. And then you're really up and running. I was talking to a manager in Montana at a community health center there, and she was telling me, like, this is just a problem that won't go away because I just, we didn't get ramped up from the beginning, and now I'm always working on it. And so we kind of hit the reset button, and we said 30 days, 30 patients, and every day we're going to talk about referrals. We're going to put some population health approaches in. And sure enough, they were able to do that, and now their care manager is full, and everybody's sort of cooking along. So I'm going to stop there and just see if there's any questions that people want to ask about collaborative care or about how to be able to do this in their health center. And I would say now probably I know in some of the states, particularly New York, that, there's hundreds of health centers that are implementing collaborative care now. We're kicking off our third learning community in the state of Montana. And so really important to, ask any questions or get this going.
And feel free to use the chat box if you have any questions or the Q&A box. And while we're doing that, Verna, if you could go ahead and pass along the presenter ball, then I could be prepared for the next few slides. So we do have one question, Verna. Alex says, I'll be starting a roundtable for behavioral health directors to assess where they're at in this. What questions would you suggest they use to get a feel for where they are at or in their journey?
Yeah, I love this question. Actually, two of them are a little bit related. So there's a couple of metrics that we look for now with collaborative care. So I call it the 90s. So to make sure that you have 90 patients enrolled, that's really your average benchmark. The second is that 90% of their time is attached to an episode. So in other words, to get really good at saying, okay, I spent 10 minutes talking about this patient in psychiatric consultation, to really make sure so that 90% of their time is attached to a billable episode, and that 90% of your episodes are billable, meaning that you had enough billable minutes to be able to bill that episode out for the month. And so when I think about QI perspectives, there's a couple of things to look at. One of them is, as an example, the number of patients who have certain treatment options, so the number of people that are in therapy as an example, but also you're really looking at outcomes here. So are 50% of your patients reaching a 50% or 10-point reduction in your PHQ or GAD scores? And then a lot of times around engagement, I will do a lot of, I'm a rapid cycle gal myself as opposed to PDSA, but do a series of rapid cycle, projects to really help with engagement. So are we going to reach out to patients on the schedule the day before and screen? Are we looking at PHQ screening rates across medical assistants to see where there might be some coaching and training, and then watching the rates? Do we know what our positive rate is for PHQs? If it's not in that 10 to 14% rate, range, then can we do some PDSA projects to be able to increase? in terms of how we're asking, when we're asking, if we're training, trying to figure out who we're missing and why, as an example.
Great, thank you. And that kind of goes into
a roundtable for behavioral health directors to assess where they are with this. I don't know, what state you're in, but what I can tell you is, I can certainly connect you with people in that state maybe, or if you think it would be helpful, I would be more than happy to come in and just go over, okay, Nebraska, awesome. And to just go over like what collaborative care is and talk about what other health centers are doing around the country so that people can take from that. And I'll just do it because I love behavioral health providers and community health centers and for no other reason than that. And Sabrina can vouch for that. I get myself into trouble all the time. So certainly if you wanted to email me, I would be more than happy to send you information, send you training materials, PowerPoint, send you billing sheets, Excel registries, whatever it is you need. I would certainly be happy to call into a roundtable.
Thank you. And we had another question that you kind of went into just a little bit. But the question asked, could you provide some examples on how we may look at this through a QI perspective or QI measure examples?
So I think, again, the 10 to 14% screening rate is going to be really helpful, and to look at it by practice, by provider, by screener, and then to really start to look at your outcomes. So to figure out a way to help meet that 50% or 10 points. So a lot of times what we'll do is look at the number of patients that were referred, or the number of people when you think about the 50% or 10 point, where are people now, how are we engaging them into care, and just say, okay, it doesn't look like we're giving people the choices, and so we're losing them in care. I had a practice the other day that did something around letting people know what their score was and where they wanted to be, and giving them a sheet that actually showed them where they were and where they wanted them to be, and had some information on depression, and did that as sort of a PDSA to see if that really impacted their outcome measures. So things like that for certain.
Great, thank you. And if anybody else has any questions, go ahead and enter them into the chat box or in the QA box. We've got just a few minutes, so maybe time for one more question. And while we're waiting for that, I'm just going to plug our session tomorrow morning. It's Strategies for Effectively Managing a Culturally Diverse Intergenerational Nursing Workforce, so we hope you'll join us. We also have a really great keynote planned from Dr. Luis Padilla from the Bureau of Health Workforce and also the Director of National Health Service Corps, so we hope to see you there. I am not seeing any other questions, so you'll get a couple minutes back to your afternoon. Thank you so much to everyone who's joined us. Thank you so much to Dr. Little for her presentation and for all of the practical tips and strategies around collaborative care. We'll see you tomorrow.
Great. Thank you, everyone. Have a wonderful day.